minutes or so, kind of giving an update on how to deal with IMHA and also ITP in vector-borne disease. All right, so let's just jump right in. And we're going to start by using these guidelines, these open source consensus statements from the ACVIM to help us determine when we have IMHA or ITP, which diseases we should be screening for, and then we'll cover how to screen for them, how to confirm the diseases, and how to treat. Right? So before we jump in, just a little quick summary. We know that these diseases are important causes of morbidity and mortality in dogs and cats, maybe more commonly seen in dogs, but certainly seen in both species. There's a change in the nomenclature, just so you're familiar. If you're reading articles, you'll know what they're talking about. The old primary IMHA or primary ATP, that true autoimmunity, is now called non-associative IMHA or non-associative ITP. There's nothing associated, no other causal thing. It's just pure autoimmunity. The old secondary IMHA, secondary ITP, that is now referred to as associative IMHA or ITP, associated with some other trigger that caused the immune attack against the red blood cells or the platelets. When you need to screen for vector-borne disease in these cases, we want to start with serology and maybe add on PCR testing. So, we'll talk about how to do that as we go along. We want to consider these immune-mediated problems in dogs or cats with vector-borne disease when we have a severe anemia that's regenerative or a marked thrombocytopenia, a very low platelet count, like 50,000 or less. Vector-borne disease is inflammatory, infectious, and by virtue of that, you can see and often do see anemias that are non-regenerative and milder, although some animals with, say, chronic Ehrlichia or Leishmania can have very low hematocrits, but they're non-regenerative anemias. And the thrombocytopenia, that's also common with vector-borne disease, if it's not immune-mediated, is usually not that low, maybe 100,000 or 75,000. We'll go into more detail about treatment later, but in general, for both of these conditions, even when there's vector-borne disease present, which you're going to be treating, you need to give them immunosuppressive therapy to stop the immune destruction of the red cells and platelets. It's safe to do that with prednisone and maybe adding an additional immunosuppressant. And in all dogs that have immune-mediated hemolytic anemia, because that's a prothrombotic condition, hypercoagulable condition, they should be on some type of thromboprophylaxis. So those guidelines that we mentioned earlier went through all of the literature to determine, based on the quality of evidence, which triggers are causally related to IMHA, associative IMHA. And that IME over on the left-hand side there stands for integrated metric of evidence. So the higher the grade of evidence proving causality, the higher up you go on that chart. So it looks like, if we see in dogs and cats evidence-based triggers for causal connection with IMHA, it looks like mostly infectious agents and some drugs. So this is helpful for us diagnostically. We know what we need to be screening for: infectious diseases. Similarly, ITP. Okay, same thing. In dogs, infections have the highest degree of evidence for causality, triggering associative ITP, along with drugs. And you can just see that in cats there aren't many studies out there. There's not much literature on ITP in cats. So this is helpful. Which infectious agents should we screen for? We can't screen for all of them. Which ones have the most likely role in triggering IMHA in dogs? And that's Babesia and Bartonella. Okay. What about in cats? It's hemotropic mycoplasma and FELV. All right, so we have to focus our diagnostics on those core causal infectious agents. In ITP, it's a little bit different in dogs. It's the kind of more common vector-borne diseases we see. It's Ehrlichia, it's Babesia, it's Leishmania. Okay, so this is the synopsis, and this is very, very clear and helpful. What vector-borne diseases should we screen for when we have a dog with IMHA? These. What vector-borne diseases should we screen for with ITP? That's the list. Some of those we can do with our SNAP testing. Some we have to do PCR testing. Okay, so this informs what tests we need to run to determine if we have an associative IMHA or ITP. If we miss that diagnosis, our treatment outcomes are going to be worse. So now just a quick review of vector-borne disease testing in general. When should we do it? Annually, as part of preventive care in all dogs. We'll talk about why that's important. And obviously, whenever you have a sick dog or cat that you suspect has vector-borne disease. How do you test for vector-borne disease? Well, you screen for exposure to the infectious agent with a serologic test, like your SNAP test, and then you confirm infection by sometimes repeating the serology, running a PCR test, or looking for evidence of the disease in your laboratory results. Important to remember, no single perfect test for vector-borne disease. Sometimes it's a combination, and sometimes it's repeating those tests. It's important to screen healthy dogs for vector-borne disease for the reasons you see here. Often clinical signs are absent, so if you're not screening, you're missing the disease. Some of these diseases are emerging in your area. They're new as diseases spread, as global movement of animals increases, climate changes. Vectors and diseases are moving into areas that they previously were not. And this is important as part of our job as One Health practitioners to identify emerging diseases that may also affect human beings. Okay. And it also lets you know if your clients are doing a good job with the tick prevention. Okay. Serology is the initial step in screening for infectious disease because it's available and it's inexpensive. The serology can detect either antibodies or antigen. It's important to know which because it tells you two different things. And clinically, we use serologic tests mostly to rule out the disease. If you have a good test with high sensitivity, the chances of false negatives are low. So a negative result rules out the disease, and you can remember that with the little trick snout. So sensitivity and N both have sensitivity and negative both have an N in them. So snout, sensitivity, and N, negative. That is a highly sensitive test that is negative rules out the disease, snout. And that's the N is the key, okay? Because sensitivity and negative both have an N. A positive result requires further testing, and we'll tell you why that is in a minute. So a positive serologic test for antibody means you have exposure to the organism. That's all you can say. A negative test for antibody says no exposure or too early. It takes about a week for the antibody test to become positive. It's different with antigen testing. A positive antigen test, it's testing for a part of the organism. So you've got it. You've got the diagnosis. A negative antigen test, if it's a highly sensitive test, you can essentially rule out the disease. Okay? So with looking at our SNAP 4Dx Plus test, which are antibody, which are antigen. The only antigen test is the heartworm antigen test. The rest are antibody tests. Okay? The Lyme antibody is a little bit unique in that it's a C6 antibody, and that's only produced when the organism is actively dividing in the dog. So it tells you you've got active infection, though it's an antibody test. We don't need to get hung up on the numbers, but ideally, the higher the better. So a highly sensitive test, that's a screening test that's negative. Snout rules out the disease. A highly specific test means that you have very few false positives. So go for higher numbers. Okay. If you have a positive serologic result on a SNAP, which would be the dot would turn blue, what does that tell you? Great. You're screening for vector-borne disease. So that's great. If you have a positive to Ehrlichia, Anaplasma, or Leishmania, you've got exposure. An infected tick transmitted the organism to the dog. That's all you know for now. Then we'll tell you how to figure out what's going on after that. If you have a positive Lyme, because of that antibody is the C6 antibody only produced during infection, you've got active infection. The same for the heartworm antigen test. It tells you have adult female heartworms there. So once the animal has been exposed, what happens? The immune system might clear the organism, no infection. That positive result is just a sign of a good immune response, no infection. The immune system may be too weak to clear the organism, and then you might have disease, active disease. The immune system could control but not eliminate the organism, so it could be occult, a hidden infection. And then sometimes these antibodies persist for a long time after the initial exposure. So you have to do more to determine the status of your patient and that involves lab work and sometimes PCR testing. If you have laboratory evidence of vector-borne disease, any of the changes seen here, you've got active disease, treat it. So this would even be a normal dog that comes in that you're screening, has a positive result on your SNAP test. How you determine whether you should treat this normal non-clinical dog? Look at the lab work. If you see any of these changes, treat the dog. If you don't, no treatment now, just keep monitoring on a yearly basis because things may develop over time. With PCR testing, it definitely has a role with vector-borne disease diagnosis, and that is in acute patients before their serologic test would turn positive. If you have an animal whose signs are more severe than typical for the disease you're dealing with, this looks like Ehrlichia, but it's really, really bad, or Leishmania, if it's really severe, that might indicate there's a co-infection, and there are infections that you can't test for on the SNAP test. You would need to do the PCR panel to identify whether you have another disease that's the cause of this severe or atypical presentation. And then another big clue that it's time to get a PCR test because there could be co-infection is you don't get a response to doxycycline, which you would expect to see a rapid improvement within a couple of days. All right, PCR testing is most often done on whole blood, but can be done on a lot of other tissues. All right, so co-infection not uncommon. The same tick can carry one or more bug, and the same area can have more than one tick vector. So PCR testing indicated when disease seems severe, disease is acute before serologic testing, or you don't get a response to doxycycline. PCR, basically, you're just looking for a little segment of nucleic acids, like very particular to the specific agent. You isolate that segment, you run it through the machine, you amplify that so you can identify very small amounts. By the time you've gone through 45 cycles, you've got billions of copies of DNA, so you can theoretically identify like one to a few organisms. You have a very low chance of missing the infection. Therefore, a positive means you've got your answer. A negative means that the organism is not there. But the organism has to be in the sample that you get when you get the sample. So mostly in acute disease. With chronic Ehrlichia or Leishmania, where's the organism? In the spleen, in the lymph nodes, in the bone marrow. So if you're testing the blood for PCR, it won't be there. Again, sometimes you do a combination of serology and PCR to improve your odds of detecting the disease, and sometimes repeating these tests are necessary. Not often, luckily, but if you're convinced you're on the vector-borne disease path and you're getting results that don't make sense, that are negative, don't give up. Keep a broad outlook. Make sure you're not overlooking any other possible cause of the signs, but repeat these tests 2 to 4 weeks later to see if you're getting anywhere. Okay, quantitative PCR, very, very helpful because it determines whether your result is clinically significant or not. A high number of DNA copies is way more relevant clinically than a very low number. So it's important and useful to have these results be quantitative. So moving on to treatment, this is all spelled out in those guidelines I mentioned. So I'm just going to do a kind of a quick review for you here in the time that we have. But for initial therapy for both IMHA and ITP, you just start with your immunosuppressive doses of prednisone. You give it once a day in the morning because that makes for less nighttime PUPD, so the owners aren't having to get up in the middle of the night to walk the dog to urinate. Dogs that are over 25 kilograms, you base the dose of prednisone not on body weight, but on surface area, 40 to 60 milligrams per meter squared per day. So you don't relatively overdose them. With IMHA, most of us, if it's severe especially, will start a second immunosuppressant initially along with the prednisone. And this may decrease the relapse rate, which is great. It may not decrease survival or increase survival overall, but you get more of a longer remission. I'm taking that, right? My go-to second choice, if possible, if it's affordable, is cyclosporin because it has no bone marrow suppression effects. You can use others, azathioprine, dogs only, never cats. You can use mycophenolate. There are other options there. And then if you have concurrent vector-borne disease, treat it. If it's a doxycycline responsive disease, treat it. And again, you have to treat both. You will not exacerbate the vector-borne disease with the immunosuppressive therapy as long as you're treating the vector-borne disease as well. If you have immune thrombocytopenia and the platelet count is so low, that the animal's bleeding. So that would be below 50 or maybe even below 30,000. Below 50,000, you're at risk for bleeding. Below 30, you could spontaneously bleed. So in this case, you want to get that platelet count up as quickly as possible, not wait for the prednisone to work. So you can do one of two things: give an injection of vincristine, which is what's mostly available to us in practice, or if it's accessible to you, human intravenous immunoglobulin. This you can get from some human hospital pharmacies. If the animal is anemic, whether due to bleeding from immune thrombocytopenia or red cell destruction from IMHA, you must transfuse, life-saving. But you want to use packed red blood cells. You don't want to give whole blood or anything with plasma in it, because that presents too many antigens into the patient where you could have a more extreme immune response. So you have to give blood. It's life-saving, but the product to give is packed red blood cells, not whole blood. We mentioned earlier for IMHA in dogs, not cats, strangely. The dogs are at risk for thromboembolic complications with IMHA. So in dogs with IMHA whose platelet counts are above 30,000, we want to give them thromboprophylaxis, and you can see the list here. Easiest is to use clopidogrel. If you have access to an oral 10A inhibitor like rivaroxaban or others, fine. Safe to use in combination with clopidogrel. Do something, okay? When they're in the hospital and they're severe, the best thing to do is just to give them good old unfractionated heparin right out of the bottle, okay? So you can see the dosages there. And you basically keep them on these thromboprophylactic medications until they're off the prednisone, which the length of therapy for these guys is long. I usually tell clients, we're going to be on medication here for 6 to 9 months or longer. So you start on the high dosages, initial dosages of immunosuppressants, and then very, very slowly taper them off. After you've got your target hematocrit for a couple of months at the high dose, then you start tapering by about 25% every 3 or 4 weeks. Go slow. Concurrently, you would need to treat the vector-borne disease, and you would use the drug for the disease that you have. And you can see the list here. There are more protocols for treating Leishmania and Bartonella, Babesia than you see here, but these are common ones and effective ones. And the key, especially with animals that have vector-borne diseases that are responsive to doxycycline, is if you're not getting a response within 2 to 3 days, you have something else going on. It works great if it's only Ehrlichia, if it's only Lyme disease, okay? If not, look elsewhere. So for Leishmania, you can see the protocols there. These are very challenging patients, as you know. The treatment can be quite lengthy, especially if you just use allopurinol alone, which some do in milder cases. As you know, for Bartonella, an effective treatment is azithromycin. For large Babesia, like Babesia canis, and the PCR test you run will speciate them for you. You would use imidocarb, and some give a second dose 2 weeks later. For small Babesia, like Babesia gibsoni, then you would use the combination of atovaquone with high-fat food and azithromycin. We'll just finish up with one of the other complications of vector-borne disease, proteinuria from the immune complexes depositing in the glomerulus. This is the current recommendation per the IRIS, International Renal Interest Society for Proteinuria. A renal diet, telmisartan as first-line therapy, clopidogrel if your albumin is low, and for you guys, I think it would be less than 20, because that is a thromboembolic disease potential as well. If you're not getting a desired response to telmisartan, at least a lowering of the urine protein creatinine ratio by 50%, if not too normal, then you can maximize the telmisartan dose, add benazepril. If hypertension is not responding to telmisartan alone, and a lot of these dogs are hypertensive, you can add amlodipine. The key is monitoring. Anytime you start telmisartan or benazepril, you want to check kidney function a week later, and the same every time you change the dose, because these medications act on the kidney. They have vasoactive properties on the kidney that can worsen kidney function. So anytime you start or change dose, a week later check kidney function. You want to give it longer for the urine protein creatinine ratio to change. So you would check the urine protein creatinine ratio anytime from, say, 2 weeks to even 2 months after. Okay. So I think that's a quick little recap. We'll just do a little review. So we want to make sure we're screening healthy dogs annually for vector-borne disease. The disease can be present even when there are no signs, and you might be identifying emerging diseases in your area, which is important not only for you to know, but for the medical doctors, human doctors in your area. We want to screen dogs with IMHA and ITP for those specific vector-borne diseases that have high degree of evidence for being associated with causing the immune disease. Initially, for vector-borne disease screening, your serologic test using a SNAP will help you determine if you have exposure, and if that's negative, you don't, right? SNOUT, a highly sensitive screening test that is negative, rules out the disease. We want to confirm whether active infection is present and not just exposure by doing more work, like we talked about. Look for laboratory evidence of the disease with acute, severe, refractory patients. Look at your PCR panels for co-infections. Sometimes, as we mentioned, a combination of serology and PCR testing is necessary, and repeating that in rare instances may also be necessary. The determination of whether or not to treat an asymptomatic dog that tests positive for a vector-borne disease is using the lab work. And if it's normal, you don't treat, but you continue to monitor annually, because following year, there might be some changes that have developed over time. Okay, with that, I thank you for your attention and have a great day.
Atenção, veterinários que buscam estar sempre atualizados no cuidado a seus pacientes. A leishmaniose é uma preocupação constante de saúde pública, especialmente em uma região endêmica como o nosso país. Para apoiar os veterinários brasileiros no combate a este grave problema, a IDEXX oferece as mais completas e avançadas ferramentas para o diagnóstico e monitoramento da leishmaniose. O teste rápido SNAP-Leish é o único com a tecnologia ELISA, padrão ouro nos testes dos laboratórios de referência. Com SNAP-Leish, sua clínica pode realizar a detecção imediata com precisão incomparável para a triagem confiável do animal. O que fazer após o resultado positivo? Independente de qual teste rápido tenha utilizado, você irá precisar de exames com o suporte e tecnologia do mais avançado laboratório veterinário do país e do mundo. O laboratório de referência IDEXX oferece um completo portfólio de testes e painéis para a confirmação do diagnóstico e monitoramento do seu paciente com leishmaniose. Através do portal VetConnect, é possível consultar o status de seus pedidos de exames a qualquer hora em qualquer lugar. E para tornar a rotina ainda mais eficiente, nossa linha de analisadores para sua clínica fornecem todos os parâmetros bioquímicos e sanguíneos necessários para o completo acompanhamento de seu paciente. Não perca tempo, converse com um representante da IDEXX e descubra como você pode elevar a precisão e rapidez no diagnóstico e monitoramento da leishmaniose em sua clínica. IDEXX, líder mundial em diagnóstico veterinário,